My name is David Leibovitz. I'm a licensed psychologist in New Jersey. I treat all kinds of issues, disorders related to psychology. I see individuals, I see couples, and I lead a lot of psychology groups. Anger is one of my specialties. I actually love to treat anger in a number of ways. One of the best ways I think to treat it is in group psychotherapy. There's a lot of dynamics that go on in the group process that are really effective for treating that type of disorder. A lot of the different techniques I use are from cognitive behavioral therapy. So we use all kinds of different things that help different folks, depending on what their issues are. Anger actually is a type of issue that has a wide spectrum of places that people are coming from. And it's obviously very effective. It depends on the situation. You know, there's times for confrontation. You know, if you're asking me if there's going to be times where a group gets a little heated, where, you know, there might be a confrontation. Perhaps I'm confronting a patient on an issue that they're very sensitive about or an area that they're sort of having some denial about. There can be some very heated exchanges. On the other hand, you know, there's going to be times where you have a room full of macho men crying. The approach I use is sometimes supportive, other times confrontational, but always we're sort of having a goal of why we're doing something. We don't just sort of say things to our patients. We always have to have in mind, you know, where is this going to go? What is this going to do to help the patient have some more insight or to create some positive behavioral change? Some of the methods I use include helping the group develop some sort of cohesion. When you use cognitive behavioral therapy, you want to use psychoeducation in a group, teach about anger, some of the negative consequences of anger, have them become aware of some of those costs. And we also want to do some role-playing in group. We do a lot of role-playing. And then we do also a lot of work outside of session. What we find is if you just lead a group and patients or clients just sort of come there and then they leave, they're lucky to retain, you know, 10, 15, 20% of what you've said during that group. So what we want to do is allow them to have this new learned behavior, these new insights, generalized to their outside lives so that it becomes real meaningful changes rather than sort of just learning something in a group setting. So I do a lot of relaxation training with patients. We do a lot of assertiveness training. In psychoeducation, we talk a lot about how anger is a normal feeling that every single person has. We're not trying to make them robots. We don't want them to sort of be real even-keeled at all times. We want to embrace the fact that they're human beings, but we want to teach them how anger can become very problematic in that anger turns into aggression. So in our groups, we target 4 specific areas of aggression that we really want to work on. The first one is aggression toward other people in terms of physical aggression. So a lot of physical altercations, fighting, punching. The second category is verbal aggression, a lot of screaming, yelling, arguments. Third category is related to aggression toward property, breaking things, throwing things, punching holes in walls. We get a lot of things like that. My favorite actual example of this is a patient who said, well, I burned down my house, but I don't think it's a problem because it was my own house. I only break my own stuff, and I get that a lot. I only break my own stuff. I don't break other people's stuff. Still, it's a situation we want to address when we talk about treating their anger. And the last category is a category that's sort of tricky. A lot of times I'll have someone in my group or in individual therapy who says, I didn't think I was angry. I'm not sure why I'm here. And we'll find out that, you know what, their aggression is turned inward. So we have a lot of suicidal thoughts. We have cutting behavior. You'll see a lot of that with some of our borderline personality patients. We have suicide attempts. So we sort of target those 4 areas of aggression, those active aggression areas, as goals. We want to have patients develop a sense of responsibility rather than blaming others for their acting out. And in doing that, they have an internal locus of control. So they say, you know what, I chose to do this. You know, when something happens or someone pushes a button, I have a choice in the matter. I don't simply have to react. I don't give other people that control over me. So we can really teach them a lot of effective methods of how to do that. I think this show is a great idea. To be honest, I think this is the perfect timing for a show like this. Anger is an illness. It affects all parts of our lives. It affects our physical health, our emotional well-being, our relationships. So I think in this current situation today, we're seeing more instances of road rage, of domestic abuse. Suicide rates are actually skyrocketing recently. And I think there's a lot of reasons for that. I think we sort of have unrealistic expectations, especially in this country, about what it is to be an American, what we can expect in our lives. You know, in 1950s we had Ozzie and Harriet and sort of had the perfect family with 2.5 kids. The reality is, it's not that easy to get ahead, and we have a lot of stressors today. Competition is really high, and so with this economy especially, and what we've seen over the last 5 years, people are becoming overwhelmed. They're letting themselves down, or they're not meeting expectations. Frustration levels are really rising. So this is a time where a show like this could be so important for people to watch at home and recognize, you know what, maybe I need help with this. Maybe this is something that I should go talk to somebody about or become part of a group. I recognize some of my own traits in these people that I'm watching right here on TV. Why am I the guy for the job? Well, I think there's a few reasons. Number one, I feel like it takes a certain type of personality to run an anger group. I think you need to have a little bit of a spark. You're dealing with people who have a tendency to have a very high energy level. You need to be able to meet them on their level. On the other hand, you need to be a strong presence because you need to set boundaries. Any effective anger management group is going to have boundaries. Patients are used to intimidating. They're used to trying to coerce people. A lot of our anger patients have developed these personality traits so that they could manipulate others or manage their way through their lives so that they could become effective. Not because they're bad people, but because they develop personality styles. So I think I'm someone who could sort of talk to a patient, be real with them, recognize when they're sort of BSing me or when they're really telling me the truth, and keep them honest so that they take some responsibility for what's been going on. And hopefully I can help motivate them. I think motivation is a big part of the leadership role in a group. Helping the patients see what they've been doing hasn't exactly worked for them, or chances are they wouldn't be in that group. So I want to sort of say, listen, where has your anger gotten you in the past? Let's talk about some of your relationships, some of your legal issues, some of your work experiences. Has what you've done in the past worked? And if not, are you willing to try something different? So I'm offering all kinds of different skills, methods, and opportunities for them to try something new and see if it works. Does this work for everybody? No, absolutely not. I don't think there's any treatment for any disorder, any illness that is 100% works for everybody. I would say that their chances of having significant gains, very great chance that that's going to be the case. Will they all be cured? No. Will this show be a springboard for them to then continue their treatment, perhaps go for individual therapy, or continue on in a group so that they can continue to get the help that they need? I think absolutely. This is a really unique opportunity.